Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for episode 1 of the Relapsed Refractory Multiple Myeloma podcast series titled Clinical Viewpoints to Individualize Bispecific Antibody Therapy. My name is Dr. Joseph Mikhael. I'm a professor at City of Hope and the Chief Medical Officer of the International Myeloma Foundation, and I'm very thankful to be joined by my dear friend and colleague, Dr. Caitlin Costello, who is Director of the Multiple Myeloma Program in the Division of Blood and Marrow Transplantation at the Moores Cancer Center at the University of California in San Diego. Caitlin, always nice to have you with me.
Joe, always a pleasure to be here with you.
Excellent. Well, in this episode, we'll be discussing the rationale and practical considerations for bispecific antibodies in relapsed and refractory multiple myeloma. I mean, there is no doubt that myeloma has just gone through this incredible evolution in immunotherapy over the last few years. And one of the centerpieces of that evolution has been the use of bispecific antibodies, for which we already have 3 that are approved and likely several more to come in the not so distant future. So I thought, Caitlin, maybe I'll just kick off with a case and we can sort of use it to think a little bit about why we would think about bispecific antibodies and then get into some of the details of how we use them, because I think this is going to be really important as we pragmatically introduce these into the community a little bit more. So I think of a patient of mine who is 70 years old. He has had multiple myeloma for over 6 years now, and he's been treated with 4 lines of therapy. So he's had pretty much the standard approach. He had a triplet with VRD and a transplant back in the day, and has now had several relapses, unfortunately, and has been treated with really the key therapies. He's had a monoclonal antibody in the form of daratumumab. He's had 2 proteasome inhibitors with bortezomib and carfilzomib. He's had 2 immunomodulatory drugs with lenalidomide and pomalidomide, and most recently actually had a selinexor-based regimen. So now we're entering that realm of bispecifics and potentially a CAR T yet, and thinking about using a BCMA-directed therapy. Maybe, Caitlin, can you tell us just a little bit about BCMA and what it is and why we might want to target it?
Absolutely, Joe. I mean, I think you so nicely described that triple class refractory patient, or that what we call penta-refractory patient, who has seen all of our main 3 classes of drugs, or all 5 of our main kind of players, or our big 5, as I know you call it, Joe, and really looking for what the next best option is. And, enter stage left comes targeting BCMA. So BCMA is an antigen that's exclusively expressed on the cell surface of those plasma cells, and very sparingly on other kind of normal tissue cells. So it really makes for an ideal target where we can really kill the cell of interest and hopefully avoid significant toxicity, like we can see with, many of our known chemos or treatments due to kind of off-tumor side effects. Now, this is particularly exciting, and we've figured out ways that we can leverage this antigen with new, different treatment options. And those include drugs that we've seen come to the market already, maybe some even removed, as an example with the antibody drug conjugate, like we saw with belantamab mafodotin. But also bispecific T-cell engagers. As you mentioned, there are 3 currently on the market, 2 that target BCMA and 1 that targets another cell surface antigen, GPRC5D. And finally, as you mentioned, the CAR T cells, where there are 2 approved now, both targeting BCMA. And these were originally approved, both the bispecific and the CAR T cell therapies, for patients who had had more than 4 prior lines of therapy. As I mentioned, the ADC, that belantamab is currently off the market, but stay tuned for more to come on that. More recently, just in the spring of 2024, now we have those CAR T cells that have been approved for earlier lines of therapy. So, for patients like yours, we have a lot of options at our kind of disposal now that we really need to kind of take the time with kind of shared decision making to think a little bit about what would be the best option for your patient.
Yeah, I mean, beautifully said as always. But I like the way you've harnessed that discussion carefully because it wasn't that long ago that sadly we didn't have hardly anything to offer a patient like this. So we're we have a good problem of having too many things to choose from. Can we start with thinking a little bit about CAR T cell therapy versus bispecific? So in my example of my 70-year-old patient where there may be an opportunity for either approaches. Can you tell me just a little bit, like in your mind, who are you tending to favor to go towards a bispecific as opposed to CAR T? I mean, we all know that CAR T is highly effective, but there are a lot of challenges in getting it and access, geography, and lots of other reasons. But maybe first, just start with what is the portfolio of that patient that you say to yourself, okay, I definitely want to go to a bispecific and maybe not go to CAR T, and why would that be?
So I think the approach to kind of these BCMA targeted therapies or immunotherapy is the same approach we take to any patient at the time of you name it number of relapse, where we incorporate into this scenario criteria that include kind of their medical comorbidities. We look at the biology of their disease. We look at prior toxicities to, or pre-existing or ongoing toxicities to prior therapies. But I think increasingly relevant here to CAR T cell and bispecific therapy is also, as you just mentioned, some of the social factors that are involved in all of this. So if I take all four of those specific criteria, I think it really identifies different groups of patients that allow you to kind of steer in one direction, perhaps bispecific, or another in as CAR T. What I think in order to make those decisions about which is the better option for your patient, I think you have to let's talk about the logistics of both of these things. CAR T cell therapy is a wonderful option as a very kind of personalized approach, but it can take some time and some organization, and that bridging therapy after the cells are being manufactured, and you really to some degree have to make sure that you are comfortable that you can keep the disease under control while you're waiting for the bridging therapy or waiting for the cells to be manufactured. As opposed to bispecifics, it's off the shelf. You can order it and get it going tomorrow. So someone who may have kind of that more aggressive relapse, or someone that you feel like you need to potentially intervene on sooner, a bispecific might be an appropriate approach there. I mean, I think there realistically and practically, there's limited availability. Some of these, specialized centers are the only ones that offer CAR T, and depending on where patients live, they may not be able to travel to a CAR T cell center. I think we're going to see increasing availability of bispecific therapies at, local or community centers as well. And so I think when we're thinking about, the comorbidities, I think we could probably get patients with similar comorbidities through either of these, just kind of with some very careful hand-holding as we'll talk about. Some of the side effects of both of those classes of drugs are very similar. Do you do anything different?
No, I mean, I think you've outlined it really nicely. I mean, basically, if someone's relapsing very quickly, I might favor the bispecific over the CAR T, as you've said. If getting access to a CAR T is going to be a challenge, then I may favor the bispecific. But as you've said, very often now, the very same places where we're giving CAR T are giving bispecifics. I do think that's going to change more rapidly over time. But no, I think you've captured it well. And in fact, I didn't give that element of detail because I kind of leading the witness, Your Honor, here a little bit. But this patient is actually relapsing very rapidly and very aggressively. And so to me, that's kind of tipping my hat to say, maybe it's better to go to a bispecific right away, because I am a little bit concerned. Although, sometimes we are using bispecifics even as bridging therapy, which is a whole separate discussion. I'm going to be more comfortable treating him in the very near future. And just to help us outline that a little bit more, we do, as you've mentioned, have 3 different bispecific antibodies that are available to us now that are FDA approved as long as patients have had 4 prior lines of therapy and have been exposed to those 3 classes that we mentioned earlier, monoclonal antibodies, immunomodulatory drugs, and proteasome inhibitors. And the first of which was teclistamab, which again directed towards BCMA, was the first that was approved based on the Majestic studies. And we saw about 2/3 of those patients respond. And we'll talk a bit about some of the challenges we have in managing the toxicities with respect to a cytokine release syndrome, initially at least, and then other neurotoxicities and infections potentially thereafter. And then secondly, very similar drug to it, although a little bit different, and I could ask you in a minute about your thoughts about the differences between these two, Caitlin, is elranatamab, based on the magnetism studies. And this is also another bispecific antibody targeting BCMA that also had about a two-third response rate in patients who were quite heavily pre-treated with, again, similar things that we have to overcome with CRS, neurological concerns, and infections. And then thirdly, there is a third bispecific antibody. We won't get into a lot of detail about it today. You've already mentioned it briefly because it has a different target. That's talquetamab. And instead of BCMA, it targets GPRC5D, which may be, generally speaking, something we've generally used after someone has had a BCMA-directed therapy. We tend to focus on BCMA or B-cell maturation antigen as you've outlined. So with those three essential options as bispecifics, if I narrow down for a moment those that direct BCMA are directed towards BCMA, Caitlin, what would make you choose teclistamab over elranatamab, or do you see a big difference between the two of them? What are your essential thoughts there?
Oh, you ask all the hard questions. I think practically these drugs are very similar, right? They're both designed to kind of handcuff, if you will, that T cell to the BCMA cell surface antigen and bring them together. I think as drug development goes, it's kind of like one's a front runner and then the next sends out data and there's a next front runner and they kind of are competing for first place. And I think practically either is a great option. Perhaps there's slight differences in, the step-up dosing and when one has to be admitted and one doesn't have to be admitted, and maybe there's some slight differences in the degrees of, higher rates of CRS. Maybe elranatamab is slightly lower. Maybe elranatamab has some kind of longer data or longer follow-up that may suggest that median PFS is a little longer. I think either is a good drug. So I think whatever you can get your hands on here is good for your patient. And we'll figure this out as we go along in terms of the long run and understanding, does one of them truly have an improved PFS or even overall survival data? I think they both have very similar infectious risks. So, I think it comes down to logistics to some degree, but both are just excellent drugs.
Yeah, I completely agree with you. I mean, it's nice to have this choice, right? It's nice to know, and some centers have favored one over the other because of the step-up dosing or contracting in their region or whatever it may be. But I think a message I would want to have very clearly stated today is that they're both very functional, active agents that if I have a patient like the one I'm describing, either one I'm comfortable with. Well, let's dive a little bit into the nitty-gritty here, Caitlin, and I know you have so much experience. You presented papers on this and you've published on this, and your group is very active. Talk with me a little bit about how these drugs are given. Is it IV? Is it subcutaneous? Just tell me a little bit about the step-up dosing part, and then we'll get into how we manage CRS in a moment. But just some of the basics about how the drug is administered.
Fantastic. Well, like we said, this is kind of quote unquote off the shelf, so it's easy for us to get the prescription, write it, and get the patient in the infusion center or admit them depending on what your center does. They are both teclistamab and elranatamab are subcutaneous injections. They both are designed with what we call step-up dosing, where, as I described to my patients, you start off with small doses with the hope that if you're going to have a reaction, it'll be a small reaction. And once the body is proven to tolerate that initial kind of dose, let's go to a slightly larger dose, where now you're giving a medium dose. And perhaps at that point, the body is, let's call it, used to or accustomed to, or has been kind of figured out how to tolerate that drug, where maybe now we're not going to have a reaction, perhaps. And we can do this kind of step-up dosing with what I describe as kind of small, medium, and large dosing so that we can prepare the body and get to the point where the immune system has been primed, it's ready, it's doing its job. But by the time you get to the treatment dose, which again is kind of the targeted dose, the immune system is already at work. You're no longer kind of having this massive kind of cytokine, activation and release where these patients are undergoing, I say, a big battle. So if we can fight our small battles first, I say, perhaps the big battle is a much smaller battle than we needed. So I think the approach, that's my silly analogy, I think the approach is to say, let's prime them. Let's give these small doses so we can avoid that big reaction, because that's what's happening, right? We are activating the T cells. We are activating those immune systems and telling them to go to war. But if we can do that in small steps, perhaps it'll be more tolerated. So when we think about cytokine release syndrome, and maybe I'll talk about this and then hand off neurotox to you, Joe. But cytokine release syndrome is exactly that. It can manifest itself as, let's call it, a bit of a quote allergic reaction, where what is most common, and for both of those drugs, it's about 65-70%, you're going to see a low grade reaction, which probably is just a fever. But these patients need to be monitored so carefully, whether you do it in the hospital, whether you do it as an outpatient, because sometimes, quote, just a fever can turn into something more, where they develop tachycardia, hypotension, sometimes requiring oxygen. And you have to be kind of ready to intervene quickly for these patients before that reaction kind of escalates too greatly. Joe, anything to add to that?
No, I think you've highlighted it really well. I mean, just as a reminder, with CRS, you want to catch it and manage it in those first two grades, where it's, as you mentioned, fever alone, or maybe a bit of a drop in blood pressure that is manageable. Because once we get to grade 3, it's a completely different ballgame. That's when people need ICU-like support and is very severe. Thankfully, when compared to CAR T, we see a dramatically lower grade of CRS, and frankly, most of the toxicities we'll describe, and that I'll describe in just a moment. But I think you've captured it very well. That's why the monitoring is so important. That's why historically this is initially was always done inpatient. I have to say, in my center now, we're trying to do this exclusively as an outpatient, but it requires a close partnership with the care partner. We have nurses that call the patients every 6 hours and check in with them, not just for fever, but also for these other toxicities that you've mentioned, that we can have this neurotoxicity. And sometimes that can just be a headache. Sometimes it can be a little bit of confusion. And we've developed a scoring system and a series of tests that we ask patients to do, which typically involves them answering some questions, writing out a sentence, a few things like that. We won't get into all the nitty-gritty of it today, but that helps us capture early, is there been a neurological change? Because we want to subtly pick up any of those changes. And if so, we may require to give them therapy with tocilizumab or possibly with steroids, as the drugs that we know have been historically very effective in reducing the grade, if not nixing CRS in the bud, as well as any neurotoxicity. But the third element that I always want to make sure we add is that with time, because these drugs are, engaging T cells that are taking out plasma cells, but they take out some of the good plasma cells as well, inevitably, almost all of our patients become cytopenic and hypogammaglobulinemic. So their immunoglobulin levels drop, so they tend to be at significant risk of infections. And so we're pretty much universally in that first month of therapy, starting people on monthly IVIG, or watching very closely for infections. If we know a patient is particularly at risk of certain kinds of infections, we may even give them prophylactic antibiotics for the realm that we know that they're susceptible to. And then we really talk very closely to community oncologists in particular, if they're going to be taking over these patients and continuing to administer the drug, that we watch very closely for infection. The last comment I'll make here, and then I'll turn it back to you, Caitlin, for any other thoughts around sort of the longer term follow-up of these patients and prophylaxis and the like, is that I really do think, and I don't think we've come up with the perfect formula yet, but I really do think we're finding that less is more when it comes to these antibodies. And what I mean by that is, if you look at teclistamab, for example, and its label, we initially gave this drug every week indefinitely. I don't know a single center in the country that's doing that anymore. After the first 8 or 12 weeks, we're often backing down to every other week, and sometimes at 6 months, even backing down to once a month, just because we know that the drugs are still very effective. But if we keep giving them that regularly, we see a lot more of that immunosuppression, and we don't want to put people at that greater risk of infection. But any other thoughts you have on how we mitigate those adverse effects and how we provide prophylaxis to patients would be great.
I think just you said it all, but heightened awareness. I mean, these are patients who are so heavily pretreated, and we're taking such weak immune systems and just asking them to do so much more to fight the myeloma, but really does spare very little to kind of protect the patient otherwise. So, the old adage of waiting for a certain level of an IgG, or waiting for, quote, severe life-threatening recurrent infections is no more. For these patients on bispecific therapies, or probably even CAR T, I think worth mentioning, should have kind of indefinite monthly IVIG as long as they're on this therapy. And I think just careful communication is so critical. And, recognizing that if there's a patient that develops a fever, for example, well after they're out of that CRS timeframe, really think about weird infections, because we see a lot of kind of these patients almost having these kind of, immunocompromised and, infections that are very uncommon, weird viral infections, CMV, EBV, adenovirus. So make sure you're thinking hard about what could be causing the fever at that point.
Excellent. I couldn't have said it better. Thanks, Caitlin, for that. I think you've summarized it really well. So in summary from this first podcast, we're blessed to now have multiple bispecific antibodies available to us in those patients that have had at least 4 prior lines of therapy. I think we're learning about the optimal management of these agents and ways to deliver them, but we're giving them subcutaneously, initially weekly, and then less frequently. We're working more and more towards outpatient measures, and we're very carefully managing those 3 important side effects of cytokine release syndrome, neurological effects, and infections. And looking to the future, I think we're going to see a lot more with these agents, but I would encourage people to join us for episode 2, where we're going to dive in even more to understand more about how these agents are used in our clinical practice. So thanks again so much, Dr. Costello, for joining me today. And I trust that as individuals have heard this, that'll help them in their care of patients for this disease.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.